Hello, welcome everybody. We're here in Seattle on the last day of CROI 17 to talk about HIV and aging. My name is Jeff Taylor, a longtime advocate, and we're here with Dr. Jamie Justice from the VA, Dr. Peter Hunt from UCSF, Dr. Seema Desai from is it Case Western?
Rush.
And Dr. Alan Landay from Rush as well. So thank you all for joining us. You're regulars on the aging panel, and we appreciate your expertise. And I would like to learn kind of what you thought the highlights were of the conference this year. So who would like to jump in first?
I can start.
Sure.
If you like. So I was very impressed that there is a growing emphasis on aging this conference, which is nice to see. There were 4 posters on the VAX index and about how it's associated with various outcomes, including non-AIDS conditions, and that COPD adds to the index, which isn't a surprise because the index doesn't really include any lung function measures, and we know that lung disease is a growing problem. In addition, a very interesting poster, 354, looked at the VAX index improvement after DAA therapy for Hep C, and showed that there was a dramatic improvement in the other measures. You know, obviously, if you cure Hep C, you cure Hep C, but the other measures, the anemia, the renal function, the liver function, improved substantially, which was nice to see. And then there were some very nice falls and frailty posters and presentations. Julie Womack, number 930, showed that there was a accentuated aging phenomenon with falls, that it's not so much that folks with HIV are at increased risk when they're younger, but as they age, their risk diverges upward quite dramatically, which I think is an important factor and something for us to keep in mind as we look at all of these aging analyses, that once people get beyond 65, you know, Victor Valcour's talked about this with cognition, we may see something very different. And so we really need to be careful to make sure we look across the whole continuum of aging. There was also a great session on fatty liver, which I think a bunch of us attended. And I was really pleased that there was an exercise intervention, poster 694. Katie Beklovsky from UMass did a short-term intervention, was able to get folks to lose weight after art therapy, which was great. And then there was some discussion of polypharmacy, but not enough.
Huge problem for all of us as we get older.
Huge problem.
Especially HIV.
Right, right.
Yeah, and I've been very interested in the immunologic events that lead to aging much further down the road, and what can be done to prevent that from happening. And we've known for a while that starting ART very early in the course of a disease really helps prevent several diseases associated with the aging process. We heard those results from START, and but at this meeting there was a poster from Jason Baker showing that even in these individuals who start ART very early, inflammatory markers continue to predict disease, even in those groups. The specific pathways that predict disease may be a little bit different depending on the end organ disease, whether it's a heart attack or a stroke, or whether it's an infectious complication or a cancer. And infectious complications in cancer seem to be, even in people who start very early, there seems to be this increased risk in the HIV-infected population, and we need to understand better the immunologic drivers of that to develop better interventions. And on the immune-based intervention front, Priscilla Hsu will have a talk coming up in just about a half hour or so, where she's using a very targeted IL-1 beta inhibitor intervention. This is, if you think of the inflammation as sort of and its impact on end organ disease like a tree, as Amy, Ellen and I have often talked about recently. There are multiple root drivers to the inflammatory state. There's HIV itself that persists even despite therapy. There's CMV and other co-infections. There is there's other comorbidities and microbial translocation. All these drive inflammation in HIV. And then there are multiple different pathways that may contribute to disease, the branches of the tree. But Priscilla's presentation on an IL-1 beta inhibitor is really looking at something that might be going after a tree trunk, driven by many of the root drivers, but might lead to many of these downstream inflammatory pathways. And time will tell whether this type of intervention will block all the downstream pathways and do so in a very safe way. And that's so that remains to be seen, but there'll be encouraging data on that front.
Yeah, certainly interleukins have been long studied in for various aspects of HIV disease.
Yeah, and they're all very different. So this is a very different type of intervention than say IL-2 that people may have heard about in the past. This intervention has much better effects on inflammation, but
hopefully fewer side effects.
Yeah, hopefully. Mm-hmm.
Dr. Desai, what stood out for you this year?
So I think this year was very encouraging in terms of the outcomes that were presented in context of aging. So we, as Peter said, we already know that immune senescence and inflammation is associated with aging. And I did see some very good posters and presentations on frailty. I think Kristen Erlandson presented a poster on frailty, and which showed that frailty along with NCI was associated with more risk of falls than NCI alone. So it was very nice to see that people were putting and studying comorbidities together, as well as there are posters on physical activity, which showed that inflammation was associated with higher CRP was associated with decreased 6 minutes walking distance. So these two posters were really outcome oriented, as well as there were many other posters related to cardiovascular disease. Most importantly, I was impressed that there were microbiome studies presented. And so we went a little bit further from just gut leakiness, and we saw association of microbiome with these outcomes. There was also a couple of papers which is into this new field of immunometabolism, where there was a paper on IDO and CVD, which was...
What is IDO?
Indole deoxygenase.
Okay.
So indolamine deoxygenase, this is an enzyme that catabolizes tryptophan to kynurenine, and this was associated with, they've done an association study with cardiovascular disease, which is really good to see because, we are taking a further step from what we knew on immune senescence and inflammation associated with aging. So I think progress was made, and really good outcome studies came merely further from the associations we knew from previous CROIs. So I think there was a step forward, and certainly intervention studies are required, as well as, most importantly, the impact of biobehavioral pathways like alcohol use on accelerating the aging process as
Can
people
you
get...
expand on that? Because most people enjoy drinking now and again, so it might be helpful for the audience.
So we and others have shown that alcohol increases innate immune activation as well as immune activation. And cell cycles more. There's increase in Ki-67. And so this is the common pathway that is associated with immune senescence. So we presented last CROI, and it is very important to know that if you had these biobehavioral pathways of alcohol or drug abuse contributing to already a high level of immune senescence, it could result in high comorbidity burden.
And let me just add to that.
Yes.
Because alcohol also increases harm from polypharmacy because it interacts with so many different medications. In the aging population that doesn't have HIV, 43% are on potentially inappropriate medications if they're drinking alcohol. So you can imagine it's only more so among folks who are on ART because many of those medications.
Now, what degree of alcohol use? Are we talking 1 or 2 drinks a day, or alcohol
so,
abuse?
So 7 drinks per week is in women is what NIAAA defines.
Okay.
And the reason I bring...
Drink a day.
Let's
be exact.
All right, okay. Thank you.
So the reason I bring this up is because these are modifiable factors. And it is, if these are modifiable factors, if one could take care of the burden from these modifiable factors, certainly there is hope. You know, that the aging processes, we know that immune aging and aging occurs in HIV infected now. And how would you reduce it by intervening these modifiable factors?
Right.
Is one of the ways of intervening the aging pathways. Besides, of course, we are going to hear Priscilla Shu now really using an IL-1 beta inhibitor. That talk is not on it, but I did read the abstract. So it takes both, you know, behavioral pathways as well as the common detrimental immunological pathways. I think will be answer to this aging.
And along with that, smoking cessation.
Yes,
and
yes.
exercise.
Yes.
Right? Also very
Yes.
important in
And-
terms of
and-
modifiable ways to
yes.
reduce your inflammation.
And there was before I give it to Dr. Landy, there was a paper on inflammation and exercise.
Yes.
So that really said that if these modifiable factors could be intervened, it could resolve it.
Right, well, thanks. I think you've covered a lot of the points, but I will bring up a few others. One that I think is always on our mind is the class of drugs and how they affect some of the aging. And I know there are a couple talks on telomere and telomerase,
Yes.
which is, many of us have been thinking more about how do the class of drugs that our patients are on affecting the aging process. And there are parts of the whole field in geroscience, and I know Peter had participated and recently published from an Annals of the New York Academy, and a review on this topic where one is starting to think about the role of studying HIV and as a model for chronic disease and aging. And I think understanding the aspects of how the antiviral drugs themselves affect the aging process is critical. It ties into what Amy just said about polypharmacy and the drug-drug interactions, but really how they're going to affect the immune system. We know and have looked at things like efavirenz and switch studies and looking at some of these and outcomes. I think those are critical. I also, as Seema just mentioned, the microbiome I think is an exciting field. That's one we're just beginning to understand in the HIV arena, and it's a new area for us to sort of think about. It does affect the comorbidities in terms of cardiovascular. Brett Palmer at this meeting presented data on metabolic outcomes related to the host microbiome, and have been doing studies in Africa on some of these, I know, in interventional. And it does lead to interventional and modifiable factors, as we know. Diet, it's one of the things that we haven't talked. Diet, nutrition, again, a big area of thinking of what happens in our HIV population. But it's not, as we talk about their aging, we're now not just talking 50, we're looking at people in their 60, 65, and there's data to suggest as people get older and older, and whether they're living in a community or in a nursing home, there's a tremendous data from the aging literature that as you move to the nursing home community, your diet changes, your microbiome changes, and all of the inflammatory markers change. So in this normal process of aging and how we live as we age, now we have to overlay that. Our HIV population are going to be in those same situations and what their living situation is like, and many of them may be in various aspects of affecting those outcomes of nutrition and health that are, I think, going to be critical for us and critical for physicians to take care of.
I think a consistent theme with that is that we really need studies that look at toxicities of ARVs in light of aging and polypharmacy. You know, the boosters don't just boost ARVs, they boost every medication practically that people take. And while people may tolerate that very well when they're 35 or 40, when they're 65, that may be enough to kick them into delirium. So I think we have to be really mindful of that and continue to be watching and trying to understand what meds are most optimal for people as they age.
Well, it's certainly something to consider as we develop new classes of drugs. Because
Yes.
there was a lot of progress this year in developing those, and certainly the older population, many of whom are highly treatment experienced, need those drugs. So it'll be interesting to see if those are friendlier and more tolerable than.
Well, and I think the long, and maybe I could ask some of my clinical colleagues, long-acting drugs, how you think those are going to affect now that we're going, and that's being discussed here, and there'll be sessions this afternoon on some of those when you're going to be taking one time a month.
Yeah.
And so
Yes.
I'd maybe ask Peter or Amy from their clinical experience what you would think about your patients.
Well, I think there's there are several issues. One of the great hopes of the long-acting drugs is that it may help address the care cascade, right there. the patients that are coming back to their clinic visits regularly and taking their medicines, well, are, in general doing well. There's still some issues that we need to, challenges of aging that we need to confront, but in general are doing well. But there's a whole group of patients who are not well engaged in care and have trouble taking pills every day. And the hope is that an injection once every couple of months might be able to keep people suppressed and reach a big chunk of the people who are right now not getting the care that they need. And there are issues, though. So one issue is that if people don't come back for their next injection, that the drug levels may decline and the virus may come back up in the setting of drug and develop resistance. And
Adherence still matters.
adherence still matters. And then the issue of toxicities that was just brought up. I mean, for most of these injectables, there will need to be a lead-in phase where you're taking pills just to make sure that you're not developing a side effect before you get a very long-acting drug injected. And then further down the line, there may be implantable therapies that might be able to be removed, and that's another strategy in case there happened to be a side effect that you wanted to stop. So.
Yeah, no, it's certainly very exciting. And I think especially in the setting of neurocognitive impairment, when people are balancing, you talked about polypharmacy, taking so many drugs, and a large proportion of those are HIV drugs, because again, in highly treatment experienced patients, they may not be able to take the easy to take one pill once a day. They're taking 3, 4, 5, sometimes 6 or more.
Right.
So if you can take that away from them, and certainly the monoclonal antibodies and some of the more innovative new drug strategies may be really useful for that population. So a kind of question for all of you, and I know this isn't, we're not quite there yet. CROI is making great strides and addressing more of these issues over the years. Certainly as people age, there's a lot of psychosocial issues that they deal with that affect all these parameters. And I was wondering what you thought of those. And I think there were a few abstracts that did address some of those, how do we get people to I guess, engage in their care more actively even as they get older and address those questions. I wondered if you had any thoughts on any of those.
There's this is a huge issue. I can speak from my own clinic, experience, and particularly a lot of older gay men, and that's a large proportion of my clinic population.
In San Francisco.
Many of them have lost their friends and lovers. In many cases, that's the primary social support. They may not have close relationships with their families, and so primary social support is often lost, and they're dealing with the challenges of aging often alone. That's a really difficult social isolation that compounds all the medical problems that
another aspect of accentuated aging. Really.
And there's increased depression, and a lot of that's driven by social factors. A lot of it may be biological factors, whereby HIV may increase the risk of depression. And so we really need to address these issues in a comprehensive way in our clinics. Our own clinic has just launched a big comprehensive program called Golden Compass that tries to help our clinic population over the age of 50, navigate the health system, integrating services, having a cardiologist on site with psychiatry on site, streamline referrals for hearing, vision, and the like, and social services. Really trying to help people, and then also a social engagement aspect to try and link people together and develop more of a sense of community.
Certainly in San Francisco, Let's Kick AIDS Survivor Syndrome is kind of a grassroots organization to address that issue.
But I think it's also important to keep in mind that there can be pharmacologic things that are happening for people
absolutely.
too. And you know, that one drink a day, when you're 25, you don't even feel it. It's kind of like, you know, you can drink coffee and go to sleep immediately, right? When you're 65, not so much. And that's also true for other things like marijuana, opioids, benzodiazepines, sleeping medications. And our patients get on these medications and then stay on them as they age, and all of a sudden they start not being fatigued. And guess what? That fatigue may be from the opioids or the benzos or the sleepers as much or more than from anything that's truly biologically happening with them.
Well, and this speaks to the whole issue of how do you marry gerontology with HIV specialty care, you know, and where should that come from? And historically, HIV providers have always kind of stepped up and gotten the expertise they need to deal with all the complications their patients experience, and this is.
Well, some are now partnering with geriatricians or with general internists.
We are
for
doing
those
that,
reasons.
and we've had some funding opportunities between the Centers for AIDS Research and the Pepper Centers, the older American Independence Centers. And we're beginning to do that. I think I mentioned earlier the field of geroscience at the NIH is really looking across all the institutes to marry what are the chronic disease. And HIV has been a great model for understanding chronic diseases as a chronic disease of aging, for which we can now learn more. And I think the gerontology world, we've implemented a short performance battery into HIV clinics as part of our evaluation. These are things that are done in the gerontology clinics. So I think they're more of a learning curve. Folks are beginning to integrate that. I also would bring up, as Peter mentioned, in San Francisco, in the aging gay male population, we have in Chicago a different population in our minority African Americans, especially the women in our Cook County cohorts, and again, they're facing our minority Hispanic and African American, there's a whole set of issues.
And have less social support than the gay community as well.
Absolutely. I mean, in terms of being, you know, not connected with the community and using a lot of the work in Chicago through the churches and the community organizations which are being reached out to. But I think it is, the social isolation is there, and a lot of need in big cities to continue to
And many of them are co-infected with hepatitis C, so they're also dealing with trying to navigate treatment for hep C.
Yeah, a lot of issues to address. Well, thank you all for joining us today. I know we all have a complications and inflammation session that we want to get to shortly, so we appreciate you joining us, and we'll talk again next year.
Thank you.
Thank you so
Thank you.
much.